Everyone. My name's Frances. Good evening, everyone. My name's Frances, and I'm the chair of the AAPC Education Subcommittee. Before we start this session, I'd like to acknowledge that we are on Aboriginal land and that we will and always will be. I'm joining you from tonight from in northern New South Wales on Bundjalung country, the home of the Widjabul people. I'd like to honour and pay my respects to my wonderful colleagues that I work with at the University Centre for Rural Health and how much they've contributed to my learning, to all the many students that I work with, and also to our community. And I'd like to acknowledge the lands, the Aboriginal lands that we are all joining on from tonight. I'd like to welcome Dr. Sharon James, who's our presenter tonight. Sharon is the board director of the Australian Primary Healthcare Nurses Association. She's a very passionate and advocate for women's health in Australia, and she has strong interests in primary care and in particular around sexual and reproductive health. We're really privileged tonight to have Sharon's expertise in unpacking and telling us about how we can prepare and enhance the scope of practice for nurses working in general practice. I'd also like to acknowledge that this webinar will be recorded and it will be available for AAPC webinars on our members on our website. Tonight, I'll be monitoring the chat, and I'm sure that Sharon would welcome questions at any time. We'd like to encourage interaction, sharing of ideas, and collaboration. And I just also wanted to let you know that we have representatives who have registered tonight from a range of different universities and primary health networks and other centres across Australia. So I'd like to hand over now to Dr. Sharon James, our presenter. Thank you.
Thanks, Frances, for that introduction. And I'd also like to thank the AAPC for the opportunity to present this evening. I also wish to acknowledge the traditional custodians of the lands and waters of where I live, the Jurunganj people, and show my respect to elders past, present and emerging. And I also want to acknowledge the added burden of I guess, for the traditional custodians over recent months, and I can't begin to understand how many people are feeling at this time. So this presentation is a whirlwind tour of a number of issues informing practice scope for general practice nurses in Australia. But the topic came about before the terms of reference or detail about the scope of practice review came out. I've been giving some thought about a number of things that have impacted my practice, and these things still remain and probably haven't been acknowledged as much as they should. And they still remain now that I'm a researcher. And I'm sure that there are people on the call who can add to the content and discussion around these slides. Before I begin, I would like to give particular acknowledgement to people like Dr. Karakama, Dr. Sue McGuinness and Dr. Christine Ashley, and of course Karen Booth and AFNA, and Professor Liz Halcombe, whose work has informed some key areas of this presentation. So let's begin, as I'm mindful that there are some hardcore primary care people wanting to also attend the Dr. Norman Swan and the Honourable Mark Butler MP webinar after this one. So the aim for tonight is to explore factors that underpin the attraction and retention of general practice nurses or GPNs in relation to their practice scope. And so these are the key points that I'll be going over. So just giving some background to familiarise people with the role and context, scope of practice of the GPNs, preparation and preparedness to work in the setting. But lastly, how we can attract GPNs and support retention in relation to those issues that I'll raise around practice scope. So who are they? Despite variability in international primary care settings, many countries, including Australia, New Zealand, and the UK, have had targeted funding and policy initiatives to enhance the number and develop the roles of GPNs to meet increasing patient need, particularly in relation to an ageing population and an increased prevalence of chronic conditions. However, they are increasingly being involved in other aspects of care, including sexual and reproductive health. And from 2022 health workforce data, we know that there are approximately 14,630 of them in Australia. But things like the small business or corporate chain conditions of work also impacts their role due to funding models. And they're federally funded rather than by state, like most acute care services. And additionally, things like registration type, so enrolled nurse or registered nurse, and I'll talk about this in a few slides' time, educational preparation, practice needs, and area of specialisation also impact practice roles. So their roles relate to many things involved in patient care, quality control, education, so organising, and that means policies, care coordination and referrals, problem solving, and that includes things like triage and emergency care, and being an agent of connectivity. So that means things like liaison, collaboration and mentoring. So key activities, amongst others, involve, for example, recalls, liaising with other health services, lifestyle risk management, and assisting in minor surgical procedures. The utilisation of skills and knowledge in undertaking these roles and activities impacts on the GPN's job satisfaction. And like any clinician, the practice scope is determined by a number of factors. And as I've just mentioned, things like registration type, but also endorsement, education, experience, specialisation and legislation. So some examples include a nurse practitioner who is an experienced master's degree prepared registered nurse with this endorsement, has an interest in sexual and reproductive health care, so has undertaken education and relevant experience related to, say, pregnancy options counselling, IUD and implant provision. And while the Therapeutic Goods Administration, or TGA, says that as from August 1st this year, they can prescribe MS2-step for early medical abortion, legislation in most states hasn't quite caught up with that yet. And I'll talk more about legislation in a moment. Another example would be a registered nurse, so that's a university prepared nurse, has had an interest in chronic disease management, has previous experience in, say, a dialysis unit, and may have done additional courses in things like immunisations, wound management and motivational interviewing to support their practice scope. And probably just another note on that is around ENs or enrolled nurses, because I'll mention those as well. And there's differences between ENs and RNs around the educational preparation, so their duration and type. RNs can supervise ENs, and RNs can develop an oversight on management plans, and RNs will have, I guess, a little more in-depth knowledge of why we do things, so the patient conditions and underlying pathophysiology as an example. So what is in a general practice nurse's scope? Ultimately, people know what they're qualified to do, but clinicians can identify and problem solve practice scope concerns themselves with support from documents like the Nursing and Midwifery Board Decision-Making Framework. So this includes determining the need or benefit to the persons receiving care, considering organisational context, a skill mix, staffing, and of course support for what you want to do, as well as clear roles and responsibilities, education and supervision or support for those involved. So it can also be informed by the national practice standards for nurses working in general practice. And I've got a little picture there of what that looks like. And while GPN role can be quite broad, and there are different registration types, like I've mentioned, the core element domains remain around professional practice. So that means like CPD or continuing professional development, relationships professionally, and leadership. The second would be around nursing care, and I've identified these elements earlier. But people need to provide comprehensive and evidence-based nursing care. There's third around the general practice setting, which considers those issues around the small business environment, data management, research, and population needs. And lastly, but no less importantly, collaborative practice. And so that discusses the need to foster those relationships in the primary care team and other agencies to optimise health outcomes for patients. So what do you need to do to prepare for work in general practice? And I'll come to transition programs from acute care setting in a moment. But as part of the mandated 800 hours for pre-registration placement for a registered nurse, for example, and it's 400 hours for ENs over 18 months. But for RNs, most placements do occur in the acute care sector. And placements in areas such as general practice have historically been harder to source. And this is particularly the case where there is demand from higher intakes of nursing students. Educational institutions can source their own placements, but AFNA does have a student nurse program where they find workplaces and supervisors for placements. There is an acute care focus in nursing education in Australia, and most students prefer to work in acute care settings following university graduation. There's also variability in how primary healthcare is offered. And from a survey published last year, only around a third of final year Bachelor of Nursing students had undertaken a placement in general practice. And given work experience is a significant predictor of confidence to work in this setting, there's more work that needs to be done here to ensure pre-registration preparation. Interestingly, this survey also found that being an international student and having a placement in general practice and confidence were all significant predictors of interest and intention to work in this setting. And so this is perhaps related to the exposure and value placed on primary health care in those countries. And like any clinician, there are also opportunities for people to undertake micro-credentialing courses. And options include things like immunisations, chronic disease management, syringing, hormonal implant insertions. In addition, there are certificates in primary care or primary health care, or you might want to do high degree coursework or research, of course. Transition programs exist for new graduates and experienced nurses and aims to address the usual knowledge and skill gaps, as well as confidence for the student, as well as the preceptor skills for staff. And some desirable elements for nurses to undertake these programs are listed on the screen. And according to their websites, places like South Western Sydney, PHN, Central and Eastern Sydney, and Sydney North Health Networks are examples of graduate orientation or transition programs. AFNA also offer transition to practice programs for those newly graduated or experienced nurses. And there's two types of programs. So it might be worth looking at their site for further information if you're interested in doing or sponsoring people through those programs. But one of those programs is funded over 10 months for MMM 3+ clinicians. So do nurses actually want to work in general practice? Well, nurses who value learning about primary health care are more likely to seek work in that setting. There's some negative attitudes that exist around limited support for career development and skill consolidation. and it being less exciting area of work compared to those high technology settings, or perhaps better suited to an experienced or older nurse nearing retirement. So nearly 44% reported interest in seeking employment in general practice after graduation, but around 58% agreed or strongly agreed that they were interested to work in general practice after. So this is after gaining clinical experience as a registered nurse, so elsewhere. And certainly when I was doing more teaching, I would ask any new first year students where they wanted to work afterwards, after they finished their degree, and they would always say something like maternity or peds or ED or ICU. However, there are some key reasons why people do choose this area of work. And it's about examples including balancing life and work responsibilities, improved working hours that suited people's lifestyles, opportunity to increase work satisfaction, to stop doing shift work, the autonomous nature of work, wanting a change from the acute care sector, and to pursue an interest in primary health care. So how does the scope of practice review relate to all of this? And the answer is really around how we can better retain but also attract people and utilise people in general practice. Public consultation closed yesterday for the scope of practice review, and this came about following the Strengthening Medical Task Force report. And in the 2023-24 Australian federal budget, $3 million has been allocated over 2 financial years for this review. And findings are due to government in the second half of 2024. And I've written the aim on the screen here. But it's really around, I guess, to identify those priority recommendations that will enable health professionals, particularly those in primary care, to deliver better health outcomes by working to their full scope of practice. So the review won't include things like personal circumstances such as motivation or PBS access. It also does not include incentive programs like the PIP and the WIP, as they are being examined as part of dedicated general practice incentives program review. And the review will consider whether they are fit for purpose to support patient-centred multidisciplinary care. And the MBS won't be included unless there are clear issues where practice scope has been impacted. So the terms of reference have identified some key benefits of working to scope. And I've listed those on the screen in terms of better health outcomes, access, improved capacity, productivity, efficiency, job satisfaction, and retention. So I'd also like to hear what practice initiatives you might have had experience with to support practice scope in your settings. So please add these in the chat, and I've added some ideal ones on the screen. So I guess do not construe practice-based documentation, so things like checklists of protocols and MBS wording as a clinician's practice scope. So these can rely on, say, the doctor to pop their head in when nurses can actually manage some of the care themselves. So things like immunisations, or documentation like this can be very task focused. So this can be problematic because as clinicians, we're actually taught to consider the whole person. And for example, if you're doing a wound dressing, you might also be talking to the patient about their wound healing and find out that they smoke, or perhaps that they have unstable housing and that's actually their key concern. So not the wound or the smoking. And as we know, supporting that person's social needs means that you're more likely to have that ongoing and continuity of care to help with the things like smoking cessation on an ongoing basis. And from the APNA's 2022 workforce survey, there are many activities that primary healthcare nurses irregularly or never do, like women's health screening or preconception care and men's health checks as examples, but there's no reason why they can't do these things. Ensuring that we value preventive care in general practice is important, and some of that occurs where practices utilise skill mix for this, but funding tends to be skewed to chronic disease management. But what if, for example, there was opportunity to offer things like preconception or interconception care before there are issues for the mother and ongoing health of the child as a result of lifestyle risk factors? So there's opportunity to better fund and support people before a chronic condition occurs. Role clarity amongst the general practice team about what GPNs can do, and having that conversation actually enhances collaborative practice, utilisation, as well as respect for what each other can do. And to quote some other figures from the APNA survey, 42% felt less than satisfied with the level of understanding by managers and colleagues about their scope of practice. And almost 37% report they're not often or regularly working to their full scope. And more than half, or 53%, of underutilised nurses requesting to use more skills and experience, but more than a quarter of those, or 26%, were denied this request. So that's noting that primary healthcare nurses broadly have highly experienced, with an average of 21 years of nursing experience, including 11 of those in primary healthcare. Supportive organisational culture and leadership is also key to this in terms of time allocation for appointments, backfill for education, inclusive language within the practice, and collaborative systems between clinicians. And that's, I think, anybody working in any healthcare setting would like those things, as they would with pay conditions for employment, so job security. And they are particularly ongoing issues in the sector compared to the competition of acute care. But also how we promote what skills all clinicians in the practice have. And that could be, practice-based web promotion, or even in the waiting room. So I'd also be interested in what you have done to enhance clinician recruitment and retention. And I've written 3 points there that I'll expand upon. So clinical experience, mentoring, orientation programs, work environment, autonomy, perceived lack of power, career development opportunities, salary and schedules have all been identified as issues in the selection of career for graduating nursing students. Similar issues exist for experienced nurses, and it is very tricky under a small business model to compete with paying conditions of the acute care sector. But this is a repeated issue described on forums too. Then there's the added issues of attraction and retention for rural and remote workplaces. And for rural and remote areas, an international review identified interventions, including supporting educational and professional development, such as targeting admission to programs for students and clinical exposure, regulatory interventions, such as recognition of overseas qualifications, financial direct or indirect incentives, such as scholarships, and personal and professional support, which included things like rural infrastructure, and of course, supportive supervision and measures to reduce feelings of isolation. I've discussed transition programs and pre-registration exposure to general practice, but pathways could also include for people such as Aboriginal health workers or assistants in nursing or AINs to build on their qualifications. In addition, there are some high schools that offer Certificate 3 in AIN, assistants in nursing, and we could look at things like re-entry course costs, which are nearly $16,000, but also numbers of non-practicing nurses registered. So ensuring we have a pipeline of nurses into general practice is needed. And this is because we know that 44% of primary healthcare nurses are between 51 and 64 years of age. So maximising team-based care is in line with the Bodenheimer's building blocks for high-performing primary care and the quintuple aim on improving people's experience of care, the health of populations, equity and access, the best use of resources, and the workforce experience. So ensuring practice autonomy would support this, as not all care requires a GP, but it is unclear what the role of My Medicare will play in this. And so just some final remarks, and I said it wasn't a long presentation, but I do would welcome your thoughts, particularly around a couple of those slides. Funding models impact general practice nurse care, and the PNIP, or the Practice Nurse Incentive Program, has not broadened the role of the practice nurse, but in a large proportion of practice has shifted the focus of the role to activities that contribute to practice remuneration. So linked to the billing of that provided by the GPs. And uncoupling nursing care from that would help. So nurses can practice independently and do so in other sectors and have professional indemnity insurance. And I guess an example of that is that nobody pops their head in to see that the community nurse has done a dressing, and a specialist on a round does not say, hang on, I'll just check that CBC line change that they're doing. There's also a lack of consistency in regulations, and the recent Therapeutic Goods Administration change to early medical abortion provision in primary care that I mentioned before is one example where nurse practitioners are now able to prescribe EMA. However, the ability of nurse practitioners to prescribe is impacted by each state's legislation. So effectively, most NPs cannot prescribe that as yet. Another example is an authorised nurse immuniser in New South Wales is able to conduct off-site vaccine clinic as long as they have the skills and education and anaphylaxis kit, etc., to do so, and the GP is easily contactable. However, if that same immuniser wants to do the same thing in Queensland, they can only do so if the CEO of a health service organisation has a health management protocol in place. And for the last point, better exposure for GP enrolls is needed, not only for students and existing nurses, but in terms of data. Data about what they do. We have self-reported interview and survey data, but in terms of occasions of service, that isn't really captured. In addition, there needs to be better visibility for the public around the care they provide in practice. And that's it. Thank you.
Thank you, Sharon. We've got a question coming up in the chat. Constance has asked, as a GP with an interest in improving the scope of GP practice nurses, I'd like to know what you think GPs can do to encourage nurses to expand their scope of practice, both in terms of their relationship with the nurses and in organisational changes.
Oh, that's a good question. Yeah, I think as far as a practice goes, it does depend on the cohort that you're caring for. So looking at the population and what your practice needs are. In terms of encouraging, I guess, education and skills, so finding out what their skill sets are, and looking at how, I guess, education could be supported in practice, but also having the protocols in place to provide that care amongst clinicians to ensure communication streams are consistent. And I'm just thinking as an example around, I know I've talked about early medical abortion, but that's because that's where I work. but ensuring, I guess, anytime there is a practice change, and ensuring that the appropriate training is undertaken, and that you have even reception staff know about the urgency of care that might be required, say an EMA, because that's very time limiting, and also what the requirements of care are. I'm not sure, what was the question again, just to make sure I've answered that properly.
Sharon, it's Frances. It's as a GP with interest in improving the scope of practice of these nurses. I'd like to know what you think. What do you think GPs can do to encourage general practice nurses to expand their scope of practice? Yeah, so what can GPs do to encourage?
Yeah. So I think I've answered that, but I guess I was asking around in terms of their relationship with the nurses. I think ensuring that everybody's on the same page with practice protocols, and ensuring people have the education and understand each other's skill sets and what they can do is the short answer.
Does anyone else have any other solutions to that question? Any other comments or questions to Sharon online, or perhaps examples of what you do in your practice? Constance, are you able to yeah, please talk to us. We can hear. Fine, thank you.
I don't want to sort of hog the conversation, but I'm sort of pro-nurse. I've been working with Caroline Gibson, who you may know, on dementia stuff for quite a long time, and she's converted me, you know, into what the nurses can do potentially. And what I find is that my GP colleagues in the practice I work at, all really busy, stressed. The patients all busy and stressed and sometimes angry, and the practice manager left abruptly, and one of the practice nurses is having to do that job, and so on and so forth. The GPs just don't sort of get it. They don't sort of get how much more our practice nurses could do if we thought a bit more openly. For instance, I find if the practice nurse does a care plan or a 75+ health assessment, I get so much more information if I actually talk to them. Of course, we don't get paid for talking to the practice nurse, but that pro forma, it doesn't tell you half of what I hear from 2.5 minutes conversation with the nurse about how the patient cried all the way through the geriatric depression scale, but answered everything perfectly, so it didn't look as though she was depressed, you know, or you know, when it says there that she eats well, that's only on some days because other days she can't afford it, and all of that. So, and there's so much rich information that would improve our patients' care that we could get from better communication, I think, and respect for each other.
Yeah, I agree. It is very hard in clinical practice when you're just dealing with what's in front of you, and essentially putting out fires. And so having the capacity and also that regular meeting time to talk through clinical issues, it becomes less of a priority.
That's true. And I'm a slow GP, and the practice wouldn't be viable if everyone worked like me. So I don't know what the answer is to that. You're absolutely right, Sharon.
Yeah.
And I see lots of older people, and there's lots of 75+ health assessments, sort of lengthy discussions about wounds and things that the nurse, you know, and I are involved in, and the patient, of course. But often they have cognitive impairments, so then it's the nurse and me and trying to put something in place. So there's all that social support stuff that they can do, the nurses, for aged care, you know, social prescribing and what groups and who, you know, who might be able to help with this issue and so on.
A lot of time spent on the phone.
Yeah. And also, you know, the whole negotiating rebates for, you know, incontinence pads and things, which I'm always asking her, could you print me out that form? I'll fill it in. She goes, oh, can't you find it? So there's so much, and it's so much more fun working that way. But then I'm older and I don't have, you know, children to put through school and mortgages and things, so I can do that.
And so how do you then, what suggestions do you have around the attraction and retention of staff in general practice generally?
I seriously think we need to talk to each other more. And there are days, I'm only working part-time, but there are days when I don't know who I'm on with.
Yep.
Don't know who the other GPs are, because I go in and get a patient, come back to my thing, go out, get another patient, come back, and I don't actually see them, and I don't know who they are. I don't know which nurse I'm on with sometimes. Sometimes I find halfway through the morning there's no nurse today. I didn't know that. So we need to talk to each other. I think we need to build a sense of belonging in general practice and working together. And we can do that by respecting each other's roles, and it shouldn't be punitive, it should be building up. So and all of that takes time, and people, you know, in the current environment, I'm getting lots of clap hands and things here. In the current environment, that people running the practices feel as though they've got to put their finances first, and because they might close down.
Yeah.
And you know, that's a very real problem. It's all very nice being lovey-dovey and putting your arms around each other and having a group hug. I'm not suggesting that. I'm suggesting a bit of a conversation from time to time to actually go up to the, I'll stop in a minute, to go up to the treatment room where the nurse hangs out and go, hi, how's it going? What's happening? Can I talk to you about this patient who's coming in later? Could you have a look at her? And she says that GPs hardly ever come up to the treatment room. I see more of you in the treatment room than any other doctor. So why? You know, it's not right. And we could all be having a whole lot more fun and enjoying ourselves, and the patients would like it better too.
Yeah, they would. Yeah.
I'll shut up. Yeah. Sorry. You can see why I logged onto this webinar.
Thanks for raising such beautiful and important, compassionate empathy. You know, that's what we want. That's the type of workplaces that we want to work in, and where we can build rapport and trust with our patients, where we can build rapport and trust with our colleagues, with other stakeholders that we might be referring people to. And I think understanding that trust and understanding those different service providers is another important aspect of how we can train our nurses and support them to work within these settings.
Totally agree. And that would answer Sharon's question. That's how we'd attract more people.
Yeah.
Any other comments that people would like to make or suggestions? You've got your hand up.
Hello, Sharon. How are
you?
Hello. Fantastic presentation, and to follow Dimity would be a very tough act. But I really wanted to kind of hone in on what you've mentioned in terms of preparing also are like undergraduate nurses for a progression, like decent career in primary healthcare. But not only that, but thinking about how they will work with multidisciplinary colleagues, mainly GPs. Do you think we could do more in the undergraduate space to promote, interprofessional education, the opportunities? Because obviously, if you can't see it, you can't be it. And I do know the quality of undergraduate primary healthcare education in nursing curricula is varied. But could we be doing more to inspire that pipeline that you mentioned?
Yeah, that's an important point, and probably something I neglected to mention. And I feel like we've had this conversation before. Yes, I agree with you. And I think having an understanding about what each other does creates that space of mutual understanding and not being scared to ask questions, as students often are, or feeling intimidated. And probably sets them up for, I guess, placement and clinical practice where they aren't afraid to ask those questions of each other. I think, and I guess you could probably contribute to this in terms of what you've done in the past for Community Health Nurses Week, or Nursing in the Community Week, sorry, where you've done blood pressure clinics and the like. And I think having that enhanced visibility actually supports nursing roles as well. So not only multidisciplinary teams, but seeing nurses operating in a community space to practice those basic skills like blood pressure.
Absolutely, couldn't agree more with you. And in terms of getting out there in the community and having that, there's great evidence to support, and I think it might be similar in GP vocational training too. The fact that social enterprise and social enterprise placements are something that has been explored in Europe, and it would be incredible to think that we could maybe look at that here in Australia as a model. But it was just listening to your presentation then, Dimity, explaining the fact that it's a team-based sport, primary healthcare. General practice is a team-based sport. So if we can bring all of those key players together, working to top of scope, best their potential, I think it's going to be a win for health outcomes for the Australian population.
Yeah.
You've just described my research beautifully. That's exactly what I'm doing my PhD on. So integrated care. And so I'm preparing an international framework that we can implement in our curriculum, that we can bring the health and social care workforce together, because we're still training our healthcare professions in silos.
Yeah.
So if we can have them on placements together, but also working across our stakeholders in the community, like our NGOs, like having students on placement in our schools, working alongside occupational therapists, for example, and across our NGOs. And that way, we then have an understanding of referral processes, working together, early intervention and prevention, and what the role of each of us play in those primary care settings. So I love that suggestion.
Yes, it could knock out the first few slides of my presentation if that was the case. So maybe, Frances, you could come back and present when you have some findings.
Yeah, absolutely. I've just got the framework now after an international scoping review, and I've also done a two-part Delphi study with experts from around the world. And the next part is I hope to interview curriculum leads nationally about how they may use the framework to guide the implementation of integrated care.
Yeah, that's excellent.
Any other comments from the audience, or final closing remarks or questions that anyone would like to add? No, if not, I'd like to absolutely thank Sharon for that lovely presentation and overview. I certainly took some notes, and I've learned so much. Thank you so much for everyone who have joined this evening, and just to let your colleagues know that if they're a member, they'll be able to access the recording of tonight's presentation. So thank you so
Um,
much, Sharon, and to
Thanks
everyone
everyone
as
for
well.
joining. Thanks,
Thank
Frances.
you. Bye.
Bye.